Everyone, thank you so much for joining us today. I am just really honored to be invited, and it was clear the first time I talked to Maureen that we had this kind of connection around sleep and our shared passion for suicide prevention, particularly among young people. And I'm grateful that all of you are here today and also dedicated to this cause. And so I'll be talking about the literature more broadly, but also some of our work on measuring and intervening on sleep health to prevent suicide in young people. As Maureen said, I'm at the University of Pittsburg Medical Center. I start off all of my presentations with some resources, just to remind us all that we can prevent suicide, that there are resources available. The 988 Suicide and Crisis Lifeline, text talk to the crisis text line, if you or anyone you know may be in crisis. We will be talking about suicide and suicide prevention today, and I know that sometimes these can be sensitive topics, and so just keeping in mind that these resources are available. So to give us kind of a roadmap for our time together, first I thought I'd start with just an update on adolescent suicide, kind of the lay of the land in terms of the numbers and risk. Then talk about why should we even be talking about sleep and focusing on sleep in terms of suicide prevention work with youth. Then I'll present some data on the association between, basically, what do we know about the association between sleep and suicide risk in young people. And then we'll end our time today by talking about what does this mean for what we do. I'm a clinical psychologist. I do a fair bit of clinical work and supervision. And so for me, the most important driving force in all of this work is what can we learn from the research about what we do different to prevent suicide in our assessment and treatment with young people. So let's go ahead and start with an update on adolescent suicide. So just to give a quick overview, and many of you are probably very familiar with these numbers, sometimes I think it's just helpful to anchor us in the scope of the problem that we're all working on. So suicidal thoughts and behaviors in 14 to 18-year-olds in the US in the past year. These were data from 2023, which is the most recent data we have available from the Youth Risk Behavior Survey. 40% of adolescents in this age range reported symptoms in line with clinical depression. 20% stated they seriously considered suicide, and 9% attempted suicide, and that's just in 1 year in the United States. So this gives us an idea of the gross problem of suicidality among our young people. And unfortunately, these rates, particularly of death by suicide, although suicide attempts also continue to rise in the US. So unfortunately, despite all of our efforts, things are getting worse instead of better. And all of this has led to recent data indicating that suicide is currently the second leading cause of death among young people between the ages of 10 and 24 in the US, behind only unintentional injuries. And so if we stop and think for just a moment about the scope of this problem among young people, the second leading cause of death in youth between the ages of 10 and 24. I know from speaking with Maureen and others at Rutgers that New Jersey has made huge strides in decreasing suicide risk among young people, and it's incredibly admirable. And as Maureen was saying earlier, it's still too many. And the global rates, and particularly the rates across our country, continue to rise. And so why is it that things seem to be getting worse instead of better? And how is it that despite all of our efforts, we really have not been able to decrease suicide risk among young people? Well, as we all likely know, suicide risk is a very, very complicated phenomenon. There is no one cause of suicide. And these contributing risk factors can vary hugely between individuals and between groups. And so it really comes down to suicide risk being quite a complicated puzzle that we're trying to crack. And so when we think about some of the risk factors that contribute to suicide risk, they include a host of different things, including psychiatric disorder, as we all know, mood disorders, depression, bipolar disorder, substance use disorders, conduct disorders. Also, the availability of lethal means increases risk for death by suicide among people who are already vulnerable. Access to firearms and medications are associated with increases in near-term risk. Also, family and environmental factors contribute to elevated risk. A history of abuse, recent loss, a family history of suicidal behavior, and other psychiatric disorders, as well as recent stressors, bullying, medical problems. All of these have been identified in the literature as risk contributors for suicide in young people. We also know that sexual and gender minority identities in young people contribute to elevated risk, certainly not because there's anything inherent about being from a sexual or gender minority group that increases suicide risk, but rather some of the adversity that's experienced as a result and stress, certainly given some of the current status of our country and some of the stressors associated with those identities. We also know that psychological characteristics like impulsivity and hopelessness contribute, as do characteristics of suicidality. And these are really just a few. And so hopefully this gives you a bigger idea of why this is such a complicated problem. And so, as I mentioned, as a clinical psychologist, I'm really interested in seeing what can we do to prevent suicidal behavior before it happens. And so I always come back to this bigger question of risk factors. If we're really going to identify individuals who are at elevated risk in near term, we need to know not only who is at risk, and this is what we call distal risk factors in scientific terms and in clinical terms. These are kind of the long-standing factors that make an individual more likely to engage in suicidal behavior at some point in their lives. Some examples are psychiatric disorders and family histories. These are relatively chronic conditions or statuses that a person has. However, what we haven't been so good at in the field of research is identifying proximal risk factors. So proximal risk factors tell us in an individual who is at risk because they have a psychiatric disorder or a family history of suicidal behavior, when are they at highest risk? At what point in time? Some examples from the literature are things like a recent loss. We know that following a recent loss, an individual who is already identified as at risk may be more likely to engage in suicidal behavior. Similarly, the period immediately following a hospital discharge is a higher risk period for suicidal behavior. And so these proximal risk factors get closer to when is a person who is at high risk just by nature of their psychiatric disorder, their identities, other factors, going to be even at greater risk, because these can signal to us that we need to do something in terms of intervention and prevention. And the field has really recognized that we need to get better at identifying risk factors that are proximal, happen in near term to the suicidal behavior. We also need to be able to identify risk factors that are dynamic, meaning that they change over time. Because if we're looking for these signals to change, we need to be able to see change in those individuals to signal that this person who's already at high risk because of their distal risk factors is entering a higher risk period. And then, of course, these factors have to be things that we can change, things that are modifiable. We can't change our family history, right? We can't change our genetics. But however, there are factors that are modifiable. And this is really how I came to be interested in studying sleep, because I'm going to argue today and hopefully present some evidence to convince you too that sleep may very well be an optimal target for suicide prevention in young people, because sleep changes happen in near term to suicidal behavior and death by suicide. Sleep is dynamic. All of us know that our sleep changes over time. We have some better night sleeps and some worse night sleeps. And Sleep is modifiable. We have excellent behavioral interventions to improve sleep. And so let's talk more about why should we be looking at sleep in relation to suicidal behavior, and particularly in young people. So first, I just want to acquaint you with the pediatric sleep guidelines from the American Academy of Sleep Medicine. And so here you can see a table that shows the recommended sleep hours per 24-hour period throughout child and into adolescent development. And most of our work is focused here on the teen years from 13 to 18 years, during which time the recommended hours of sleep are between 8 and 10 hours for optimal health. And unfortunately, what we know is the gross majority of youth in our country are getting nowhere near the optimal amount of sleep as recommended by pediatricians, by the American Academy of Sleep Medicine. These are some older data from 2014, although the findings have held across the last 10 years. So what you can see here is this is from a huge sample of teens in the United States between the ages of 14 and 18. And you can see over here, this is 8 to 10 hours described as borderline optimal and optimal sleep. And the percentage of youth in the sample who said they were getting that much sleep. And what you can see here in the red bars is that almost 75% of the sample of young people were getting nowhere near the optimal amount of sleep between 8 and 10 hours, meaning that 3/4 of youth in our country are walking around sleep deprived. And so why is it that young people are having such short sleep in such high numbers? Well, there are very good reasons for it, and they're actually from a range of domains. The first are biological. So we know that there are physiological, biological changes in sleep that happen at puberty. So the first is our young people tend to become night owls during at puberty and thereafter, meaning that their circadian rhythms start to shift later. So our bodies produce melatonin to give us the signal that it's time to start winding down to go to sleep. And it turns out from this graph down here, you can see that as puberty advances, these Tanner stages up here, so does melatonin onset. And so basically what that means is our body is telling us through puberty to go to sleep later. And so on average, adolescents tend to become more night owls. They want to go to bed later and also sleep later. We also know that physiologically, sleep becomes lighter during adolescence. So slow wave sleep actually declines by 40% during and through puberty. So our teens are actually sleeping lighter than they were previously and even thereafter. And so all of this leads to this preference for later bedtimes and later wake times. However, what we know is that our environment is actually very much at odds with what adolescents' bodies are telling them. And so to start, we know there's a decrease in parental control during this time. And so for most of us, I have a teenager at home as well. I don't tuck in my teenager anymore, right? Many nights, to be honest, my teenager's going to bed after I am going to bed. So there's this decrease in parental control where when our young people are smaller, we're really monitoring bedtime more carefully. Whereas when they're getting older, there's just less parental control, which is developmentally normative and yet can also lead to some behaviors that interfere with good sleep. We also know that homework and school activities can get in the way of optimal sleep. If school gets out at 3 or 4 o'clock, our young people are involved in sports or after school activities. They may not get home until 7 o'clock, eat dinner, do their homework, want to spend some time texting with friends online. And that means their bedtimes are getting later and later and later. We also know that with the advent of our electronic devices, most namely our cell phones and tablets, that this exposure to social media, and it's particularly the exposure to light that can get in the way of our sleep. So we know that that exposure to bright light via screens actually inhibits the release of melatonin in the evening. And so our screens can actually interfere with our ability to fall asleep. And recent data indicate that 97% of teens actually have an electronic device in their rooms. So there's both the sleep interference, but there's also the emotional interference. I can tell you quite honestly that the last few nights, or maybe the last couple of weeks, I have been prone to looking at the news in the evening on my cell phone. And so not only is the light interfering with the ability to fall asleep, but the emotionality that goes with reading some of those things, the emotionality for our teenagers that can arise when they're texting with friends, seeing things online, can also get in the way of sleep. So all of these social and environmental changes. And then of course, early school start times. I'll be curious to hear from you all about school start times in New Jersey. I live right down the street from a high school here in Pittsburgh, and the high school starts at 7:05. And so here our young people are wanting to stay up much later, and yet our high school starts 2 hours before our elementary school. And so we know younger people are actually going to bed earlier. And so we kind of socially have things flip-flopped, where our expectations of adolescents to be able to get up in time for school and go is at odds with their biology. And so what does all of this mean? Well, what we know is this basically culminates in a host of problems for young people. And so what we know from the literature, I tried to summarize in this one kind of overwhelming slide that I'll try to walk you through. But essentially, when we are not getting enough sleep and we are not getting good sleep health, that can impact almost every system of our body. So the first here is our cognitive systems, our abilities to think clearly, to concentrate, to make good decisions for ourselves. All of these are significantly impacted in a negative way when we are not sleeping well. And this is particularly true among adolescents. Poor sleep also impacts us negatively emotionally. Young people who don't get enough sleep are more likely to have more depressive symptoms, be more reactive emotionally, have more negative affect, so more depression, sadness, hopelessness, and less positive affect, joy, and happiness. And also, just in general, more difficulty regulating their emotions. I think this is probably true for most of us. Think back to a night where you didn't sleep well. The next day, maybe you feel a little more reactive, a little more irritable. In terms of behavioral effects on sleep, young people who don't get enough sleep are more impulsive, more likely to engage in violence, make more risky decisions, including risky sex, have more delinquent behavior and substance use. In terms of physical effects, young people who don't get enough sleep are more likely to gain weight, to be obese, to have diabetes, to reach for high fat and high carb foods like the donut showed here. We're all looking for ways to get a quick energy burst. Our bodies tell us that when we're sleep deprived and tired. Young people who don't sleep enough tend to have more acne and are perceived as less attractive by their peers. It's also true for adults, by the way, from the literature, and also more likely to have inflammation, which can make it more likely they're getting sick often. Neurobiologically, we know that our brains simply don't function as well when we're not sleeping well in a host of different areas of the brain, as supported by a range of neurobiological studies. And so all of this gives a picture of the myriad of ways that poor sleep affects young people on a day-to-day basis. And of course, we know that sleep problems are also a symptom of psychiatric disorders like depression, anxiety, ADHD, and substance use disorders, which leads us to this chicken and egg question, right? Is it that the young people who are having psychiatric disorders like these are having more difficulty with their sleep, and that's leading to suicidality, or the other way around? We also know, though, that sleep problems are a risk factor for developing psychiatric disorders. So young people who are having sleep problems tend to be at higher risk for onset of psychiatric disorders later in life. And so it's really important that we recognize that young people who are having sleep problems may be in the prodromal stages of developing a psychiatric disorder. Unfortunately, we also know that young people who have depression or anxiety and also sleep problems are actually less likely to respond to our evidence-based treatments with positive outcomes. So, a youth who, for example, is depressed and having a lot of sleep problems is actually less likely to have a good outcome in terms of their depressive symptoms than is a youth who's having minimal sleep problems. So now let's talk a little bit about the Sleep and Suicide Association. So I first got interested in this question as a postdoc here at the University of Pittsburgh. So my mentor, Dr. David Brent, who's a thought leader in the field of suicide prevention among young people, had a data set in which he was able to interview the family members of young people who had died by suicide. Here you can see in the red bars, there were 140 youth who died by suicide. And then in blue is youth who were controls. So they were matched for age and geographic area. And what he did was interview the young people themselves who were the controls and interview the family members of the youth who had died by suicide about the week immediately preceding their death for the youth who had died by suicide as compared to a random week for the controls. And I asked him because I got so curious about this question, do you have any data on sleep? Because they had this proximal data the week before these young people died by suicide. And he said, yeah, actually, I think there's some questions on sleep in there. You can take a look. And so this was really my first foray into the data. And what you can see may not be at all surprising to those of us who are here today, but certainly served as kind of a wake-up call, I think, for myself and many others, that this is really an issue for us to be more closely attending to. Essentially, what you can see that there were grossly higher numbers of youth who died by suicide, whose families reported that in the week before they died by suicide, they were experiencing insomnia, too little sleep, hypersomnia, too much sleep, and any sleep problem at all as compared to the controls. And this finding even held after we controlled for psychiatric symptoms like depression and anxiety. And so really telling us that there is something about sleep that was changing in that week immediately preceding death by suicide in these young people. Some of the other early work was from Winsler and his colleagues, and you can see here the association between the number of hours of sleep here on the x-axis that adolescents were getting, and the percentage of participants who reported in green, hopeless thoughts, in yellow, suicidal ideation, and in blue, attempted suicide. And so I show this graph because I think it's one of the most clear messages that there is actually a dose response effect between the number of hours of sleep a young person gets and the likelihood that they're going to experience hopelessness, suicidal thoughts, and attempted suicide. So if you go to the left here, if you can see my mouse, with each hour less of sleep on average a young person gets, their risk for these problems increases. And then if you go to the right, you can also see kind of this J shape in these curves. You can also see that actually too much sleep can also be a problem. We just looked at the numbers on hypersomnia among the youth who died by suicide. But it also really draws our attention to kind of this optimal window of 8 to 9 hours of sleep on average for young people being associated with the lowest risk. But we also know that it's not just about how many hours someone sleeps, although that's certainly important. And so I want to show you this framework for sleep health that was set forth a couple of years ago by my colleague Dan Bicey here at the University of Pittsburgh, for us to think about all the different ways that sleep can be problematic or impaired. One is regularity. So this is about, are we going to bed about the same time every night and waking up about the same time every morning? And in fact, what we know among our young people is that there are really huge rates of irregularity among adolescents, because what they do, unfortunately, is have to wake up really, really early before their bodies are ready during the school week. And then anybody who lives with a teenager or knows a teenager or kind of remembers being one themselves, our young people are sleeping hours and hours and hours later on the weekends, waking up at 1, 2 o'clock sometimes to try and catch up on their sleep. And this is an example of irregularity in their sleep. Ideally, we're waking up and going to bed about the same time every day. There's also satisfaction. Sometimes you might sleep okay seemingly, but you don't actually feel like you got a good night's sleep. There's also alertness during the day. How awake do you feel during the day? The timing of your sleep, what time are you actually going to bed and waking up? Sleep efficiency refers to the percentage of time that you're in bed that you're actually sleeping. And so ideally, that's 100%. You get into bed, you fall asleep a couple of minutes later. When your alarm goes off or you wake up in the morning, you get out of bed. But if you've ever had a sleepless night, which is many of us, you might be tossing and turning. So spending a fair bit of time in your bed that you're not actually asleep. And then, of course, there's total duration of sleep, but that all of these are actually very important to our overall sleep health. And so this table just summarizes all of the studies that have been done to date on a wide variety of ways in which our sleep can be disturbed, and showing places where there has been a demonstrated association between this sleep problem here on the left and death by suicide, suicide attempt, or suicidal ideation. And so what you can see here is that in almost every row and column, there are X's, strong associations between everything from insomnia, nightmares, poor sleep quality, long sleep, short sleep, even taking sleeping pills, and a range of from suicidal ideation to suicidal behavior to death by suicide. And so increasingly, the research is really adding up to support this very strong association between a range of sleep problems and suicide risk. And so this led to one of our research studies that I conducted in collaboration with my wonderful colleague in sleep medicine, Dr. Peter Franzen, shown here. So this was a study that was supported by the American Foundation for Suicide Prevention that Maureen spoke about earlier. It was also funded by the University of Pittsburgh CTSI, which is our Clinical and Translational Science Institute. And so basically what we wanted to do in this study was to really establish this prospective association between sleep problems and suicide risk in young people. Because one of the shortcomings of the literature of the table I just showed you is that the vast majority of those studies were what we call cross-sectional, meaning that they ask young people, over the past year, have you been suicidal? And over the past year, have you had sleep problems? Which is very important to know. But the problem is it doesn't really tell us about the temporal association, right? It tells us more about distal risk. It also doesn't necessarily tell us that the sleep problems preceded the suicide risk, which is really critical for us in terms of being able to prevent suicidal behavior. And so our goal in this study was to try and address those shortcomings in the literature. And so the way that we did that, we recruited young people between the ages of 13 and 24 from our intensive outpatient program here at the University of Pittsburgh for young people who are at risk for suicide. These are young people largely who have been diagnosed with depression and or anxiety. Many of them are stepping down from inpatient care, either for a recent suicide attempt or severe suicidal ideation. For some of them, this is to try and deter an inpatient hospitalization for suicidality. And what we did here was follow these young people over the 3 months that they were engaged in our intensive outpatient program. And during this time, we did a couple of things to very closely monitor their suicide risk and their sleep. The first was we had them wear what we call an ActiWatch, which is basically just a research grade Fitbit or Apple Watch that gives us very fine-grained data on their sleep throughout the course of the study. So they wore the watch through the entirety of the 3 months. We also had them fill out daily cell phone ratings, once in the morning and once at night, both about their perspectives on their sleep, but also about their mood symptoms, substance use, as well as their suicidal thoughts and behaviors over this period of time. And then in addition, we had them complete weekly clinical ratings. So we're collecting very, very detailed information on a daily basis to try and better understand this sleep and suicide risk association in a very high-risk sample. And so what have we been finding? So the first is what time of day we see suicidal ideation is most common in these young people. What you can see here is probably not surprising that that suicidal ideation peaks in the early evening and evening hours among these young people. In part, we hypothesize because that may be time when they are less distracted, not at school, maybe because of the family environment or the home environment, maybe because of things that are happening on social media. We're not entirely sure, but it does tell us a little bit about the highest risk periods in young people who are already at high risk. What did we learn about the young people's sleep? On average, they were sleeping about 7 hours, which again, we know is below that 8 to 10 hours recommended. In terms of their sleep efficiency, it actually wasn't too bad, though lower than what we generally expect in adolescents. Generally, we're looking for about 90% in adolescents and about 80% in adults. Our sample was sleeping 80% of the time that they were in bed. In terms of their sleep onset latency, this is just our fancy term for how long it took you to fall asleep. Not too bad, about 18 minutes. We're really looking for something between 10 and 20, though anything below 30 is within the normal range. Interestingly, 38% of the nights, young people reported that they had nightmares, so very high frequency of nightmares in the sample. And then each day we asked the youth to tell us, like, how good or bad was their sleep on a scale of 1 to 100. And on average, they were saying it wasn't great, about 51. And then this was really kind of our key question in the study, which is to try and better understand this near-term association between sleep and suicidality. So here I'm presenting you data on, does last night's sleep predict today's suicidal ideation? And these are what we call within person risk. And so this is as compared to that person's sleep onset latency, sleep quality, and nightmares, because we know there are a lot of individual differences. And so essentially what we found is that as compared to what's normal for you over this period of time, on days where it takes you longer to fall asleep, you are at increased risk for suicidal thoughts the next day by a rate of about 1.5 times. So that's the sleep onset latency bar. The next is sleep quality. On days where you report that your sleep is worse than it usually is, again, associated with elevated risk for suicidal thoughts the next day. And particularly potent in our sample was the association between nightmares last night and elevated risk by almost 2 times the next day. And so these can be very specific in informing what it is that we want to be asking young people about in terms of really monitoring their elevated suicide risk. Another one of our questions was not just, does sleep disturbance last night affect suicidality today, but also this question of like, how? What is the mechanism whereby poor sleep is leading to suicide risk in young people? One of our hypotheses was this may be about our reactivity. Remember, we talked about how it's so much harder to regulate our emotions when we've had a poor night's sleep the night before. And so what we asked the young people about on a daily basis was how enjoyable or pleasant was your most positive event that day and who was involved. We also asked them about their most stressful or upsetting event that day and who was involved. So the happy face and the frowny face. And what we found, I think actually really does make a lot of sense and was the first time it had ever been demonstrated empirically in the literature. And so essentially what we found is on a night where the youth got less sleep than normal for them and poorer quality sleep than what was normal for them, the next day they reported less reactivity to positive events, meaning something good happens, the smiley face here, and they're just kind of like, whatever. Sometimes what we think of as anhedonia as a symptom of depression, but relatively for them, more anhedonic than what was normal. So they have good things happen and they just don't care, right? On the flip side, after a poor night's sleep, when the young people reported stressful, upsetting things happening the next day, they were more likely to have a really big emotional reaction, more difficulty regulating their affect in response to normal everyday stressors happening. And that it was actually through both of these pathways that we saw increases in suicidal ideation. So poor night's sleep, things are just happening as they're living their lives. Their emotional reactions are either blunted when good things happen or exaggerated when bad things happen, and that's associated with increases in suicidal ideation. And so all of this has really led to our group trying to think more about how can we use this information. Part of my dream about where we can go with this is that we can monitor sleep health in real time. Like half the kids even have their own Apple Watch. These are our actigraphs, but actually now a lot of the commercially available products are actually quite good at measuring sleep. The truth is even our phones that are in our pockets within arm's reach, and certainly for our young people always close by, are actually quite good at determining sleep-wake as well, just based on our patterns of use. And so if we were able to monitor among young people who are already vulnerable, periods where their risk is increasing because they're sleeping more poorly, then potentially could we have alerts to the young people themselves to use their safety plan, reach out to their team, their therapist, their doctor, their friends, seek support. Also potentially to alert providers and parents that, hey, your young person might be entering a more elevated risk state. That would be for young people during high risk periods. During periods of lower or increasing risk, this potentially could be used to inform sleep health promotion strategies. For all of us, this is true that likely we can all sleep better than we are, and we know there are interventions that work. And so let's spend our last couple of minutes together talking about assessment and treatment. What does all of this mean for what we do in our work with young people? So the first is assessing. We don't know about sleep unless we ask. And so among young people who are depressed, anxious, at risk for suicide, the recommendations are that we first start by asking about a recent typical night and a 24-hour period and being very specific. It might be an overview of the preceding day or a recent day, and finding out what do they do before they go to sleep? What does their wind down period look like? And we'll talk more about this in terms of intervention. Are they on their phone right up until the minute that they try and fall asleep? Are they reading quietly in dim lights, which is more what we recommend, but having a period where they're winding down and limiting blue light. Also, a pre-sleep period from in bed to lights out. What are they doing from the time that they get in bed to the time that they're trying to fall asleep? Again, really recommending dim light, quiet, making the setting very comfortable for them and conducive to sleep. And then, of course, identifying thoughts, feelings, and behaviors that go along with sleep. For many of our young people who have trouble sleeping and ourselves as well, there can be great anxiety about, am I going to be able to fall asleep? What if I can't fall asleep? I'm going to be so tired tomorrow. I'm not going to be able to do well on that test. And certainly, increasingly, we've become aware of issues in the sleep environment in terms of safety, in terms of noise, in terms of comfort. And so really trying to assess all of those factors. Part of what we're looking for is the regularity of bedtime and wake time in young people. And so asking about what time do you go to bed and about what time do you wake up? And of course, really focusing on any differences between weekdays and weekends. What we recommend, and this is a really tough sell to many young people, is no more than plus or minus 2 hour difference between weekdays and weekends, which can be really tough. And what we know is particularly that morning wake time is so critical in anchoring someone's circadian system. How long is it taking them to fall asleep? Once they do fall asleep, how often are they waking up throughout the night, and how long are those awakenings lasting? Are they having nightmares? And if so, are they remembering them in the morning? Are they waking up from their nightmare during the dream? And then also finding out what their daytime functioning is like. Are they sleepy during the day? Do they fall asleep on the bus, in class? Are they taking naps after school and then having difficulty falling asleep at night or not? And so all of these are some considerations in terms of assessing sleep in young people. I also love a good sleep diary. And so, when in the context of ongoing work with young people, where we're trying to target improving their sleep, having them in some way, shape, or form track their sleep, it really helps us to clarify patterns over time. And particularly in our young people who are at risk, recognizing any associations between sleep last night, the night before, even the night before that, and depressive symptoms, anxiety symptoms, functioning, and of course, suicidal thoughts and behaviors. And this can also help inform our interventions and goals, and to monitor progress if we're trying to target sleep in our interventions. And so this is just an example of a sleep diary. Increasingly, our young people really like to use apps to track their sleep. There are hundreds of thousands of free apps at this point for young people to download. There's not a particular one or more that I recommend. Honestly, the best one is one that they're going to use. And so you can check out a couple of here. There's a recent review paper that talks about some of the strengths and weaknesses and pros and cons of different apps available. There are also some sleep diary templates that you can download here on the American Academy of Sleep Medicine website and the National Sleep Foundation website. Some of the things that we track is not just how much they're sleeping, but of course the timing of their sleep, how often they're waking up. Did they have nightmares that day? Caffeine is a huge one, and not just how much caffeine they're consuming during the day, but also the timing of their caffeine intake. We can talk more later if people are interested about energy drinks and kind of how that seems to be interfering with some of our young people's sleep. Also, have them just rate their sleep quality, could be on a scale of 1 to 100 or with whatever they're comfortable with. Tracking their physical activity, what did they do during the day? Because we know that you need to expend energy during the day in order to sleep well at night. And then, of course, daytime sleepiness. Are they falling asleep during the day and or taking naps? And so in terms of intervention, part of the really good news about recognizing this link between sleep problems and suicide risk is that sleep problems are modifiable. We have behavioral treatments that are quite effective for improving sleep health. And they're relatively brief, highly implementable, and like I said, largely effective. The other thing that I really love about working on sleep with young people is that by and large, it's far less stigmatized than some of the other things we sometimes talk about, like depression, anxiety, psychiatric symptoms, trauma, abuse. We all sleep. We all have difficulty sleeping sometimes. And especially with our young people, sometimes they come in, they're not ready to talk about some of the emotional feelings, challenges that they're having. They may not have the vocabulary for it. That can sometimes take much time to build that trust. Whereas most kids are pretty ready and willing to talk about their sleep and the problems that they're having with their sleep. And so, again, one of the reasons that I've been drawn to really trying to focus on this area. One intervention that I've been particularly drawn to is what's called the transdiagnostic intervention for sleep and circadian dysfunction, which is a really long title that we've come to call TSC, or is also known as TransC in the literature. Basically, what this intervention does is put together a host of different evidence-based approaches to dealing with sleep problems. So we know that there are evidence-based approaches for treating nightmares, for treating insomnia, for treating hypersomnia, for treating circadian reversal when you get your days and nights confused. And for most of us, we don't have time to learn every evidence-based treatment and read all of the 50 books that there are on this topic. And so this intervention, developed by Allison Harvey and Dan Bicey, essentially puts together the evidence-based components of these treatments into one intervention. So it's really like a modularized intervention. It's been studied in a couple of different populations to date with really promising outcomes. And I think the take-home message here is that intervening on sleep can potentially impact depressive symptoms, anxiety symptoms, and suicide risk. And so this is really an area for future study that myself, our group, and many others are continuing to pursue. And so to boil down just some of the evidence-based components in this Harvey and Bicey book that are really across these empirically supported treatments. And we'll do this for our last couple minutes, and then I'll open it up to questions. The first is, like I said, we're really trying to regularize sleep to the extent that we're able, because every hour counts, if you'll remember back to that Winsler graph. And so the hope is no more than plus or minus 2 hours between weekdays and weekends and across the week in terms of bedtime and wake time. Also setting aside a wind down period. Our bodies need time to settle down before we can just go to sleep at night. On average, we talk about 30 to 60 minutes with our young people, during which time they're engaging in relaxing activities and trying to reduce light, especially from technology. Our group has actually been encouraging youth to use blue light blockers because for many of the young people, they're just not willing or able to put down their phones or their screens in the hour before bed. And there are some data to show that using those blue blockers that you can get at the drugstore for less than $10 actually can be really effective in helping people's bodies to wind down at nighttime if they're exposed to bright light. The wake up routine, it should be brisk. For those of us who might like to snooze, it turns out, I have bad news, that snoozing actually is not high quality sleep. And so what we want is people to have a brisk wake up routine. Your alarm goes off, you wake up, you open your eyes, you put your feet on the floor, and you get out of bed. No snoozing. Also, getting some sunlight. Light really helps to set our circadian systems. And so whether that's opening the blinds, turning on some lights, getting moving, that's the cue to our bodies. It's time to start the day. We also encourage people to use their bed only for sleeping. This used to be called sleep hygiene. Now we call it sleep health in the field. But especially during the pandemic, so many of our young people were doing school in their beds. They were doing therapy virtually in their beds. They were doing everything in their beds. And what we know is that that then cues your brain that your bed is for a lot of things and not just sleep. What we want our brains to remember is that the bed is for sleep. And so if we're in bed and we're not sleeping, that's a problem, especially over long periods. And generally avoiding naps. Naps aren't entirely bad. And what we know is, especially if young people are having trouble sleeping at night, we want them to consolidate their sleep, meaning less sleep during the day, so your sleep is more compact during the night. Some other general guidelines for improving teen sleep health: building commitment. Change is hard for all of us, and particularly around sleep and our motivation to change these things. There are good reasons that we all have trouble sleeping from time to time. And so, really, just focusing on any small change that the young person is willing to engage in, really recognizing that even 1 hour more of sleep can make a huge difference in terms of mood, symptoms, and suicide risk. Engaging parents as is developmentally and clinically appropriate. Sometimes parents can be helpful to the process, sometimes not so much. And so being mindful about that. And then really troubleshooting all of the things that get in the way of a good night's sleep. My last thought before we move to question and answer is, kind of a politically motivated one, which is making the case for later school start times. Several of us in the field and across pediatrics, among a host of other organizations, including teachers, have been advocating for later school start times, particularly for adolescents, given this mismatch between when we want kids to get up for school and what their physiology is telling them. And so in a couple of different states, they've implemented this, and the data are very, very clear that that delaying school start times among adolescents is associated not only with more sleep, but a host of positive outcomes, including higher attendance, less tardiness, lower dropout rates in high school, higher test scores and higher grades, as well as lower depression. Unfortunately, nobody's been powered to look at suicidality, but I would hypothesize that we might be able to see something there too. And the hope is that more schools across the country will implement these later school start times. And so to wrap up, we know that adolescence is really this increased period of vulnerability, not only for depression, anxiety, and psychiatric disorders, but also for sleep changes. And that the literature is quite clear that there's a strong association between sleep health problems and suicidal thoughts and behaviors. We have treatments that work for sleep, and the hope is that this will offer a promising strategy for identifying youth at risk and also for preventing suicide in vulnerable youth. So more to come on that. I want to thank you all for being with us this morning. Thank our funding sources, without whom none of this would be possible. I get the good fortune to share all of this with you, but it's lots of teams of folks who make all of this possible, and particularly the participants and their families who engage in our research. Without them, we would have no data to be able to answer all of these questions. So thank you all so much for your attention.
Dr. Goldstein, I do have, if we have a couple of minutes, if that's okay with you. There are a
Absolutely.
couple of in the chat that people have
Yes, I have
shared
a
with me.
question, or I have two questions as well. When you're
Okay,
through
is
one.
there any indication this research would carry over to adults as well, or is there any other research on adults regarding this that should be looked at?
Yes, the literature in adults is quite similar, showing a pretty strong association between a range of sleep problems and suicidal thoughts, suicide attempts, and death by suicide. And there are several studies ongoing also in adults to try and really show this proximal association. I honestly think that because technology is what it is now, we're much more able than even 10 years ago to monitor these things in real time. So I think that's really helped the field, both for young people and in adults as well. There's also a particularly strong burgeoning literature in geriatric populations. So unquestionably, I think there's a lot to be said for this. Of course, the developmental sleep needs are very different between young children, adolescents, adults, and those change again as folks age into older adulthood.
Another one was about more of like becoming involved in ongoing research. And I will throw out here too, in New Jersey, someone asked, are there similar research going on in New Jersey? I would point to Dr. Evan Kleiman's suicide prevention lab out of Rutgers. So
Yes.
you could also shoot, me an email. I'll put my email in the chat, and, they do some fabulous work as well. I also too, Dr. Goldstein, there's been numerous requests about slides. I know there's a recording. I always say too, like, you'll share with me what slides, it's not always the whole presentation, sometimes it's a shortened version, but we'll share whatever, whatever you share with me, we'll share out. So, so there's definitely, that was asked at least 15 or 20 times. So I want to just let you know, there's really an interest and there's a lot in the chat. What are your thoughts on using sleep aids such as melatonin or even medication prescriptions by a doctor?
That's a really good question. So I am not an MD. I will just put that out there. I think that it should be carefully discussed with any clinical team. The data in depressed adolescents show that actually those young people who are getting evidence-based treatment for depression, who are also on a sleep medication, not including melatonin, this study was done about 15 years ago, actually had worse outcomes. Now, we can't say that it's because they were on sleep medicines, nor can we say it's because of their sleep problems. It's just an interesting association. And as a psychologist, what we can say is that these behavioral interventions to help improve sleep tend to be more effective over the long term if you can get a young person to engage in them. It's also true that it takes time and commitment. In terms of melatonin, I mean, there are definitely some research to support the use of melatonin. What we don't know is about the long-term effects on melatonin in young people. So that's an open question. The other thing that I like to really highlight, how often we see young people coming in talking about melatonin as a sleep medicine. And so they say, oh yeah, you know, I was trying to go to sleep, I couldn't fall asleep, and so I took a melatonin. And so what we know is that melatonin is not a sleeping pill. Rather, the way melatonin works naturally is released in our bodies is about an hour to 2 hours before our bodies are ready to fall asleep. Our bodies start releasing melatonin, and that's our cue to our bodies, unwind, time to go to sleep, right? And so that's the way that melatonin works. And so the idea is when folks are prescribed melatonin, that they'd be taking the melatonin about an hour before they want to fall asleep, because that's the way that biologically melatonin works. And I think for whatever reason, it seems we see this often. I'll be curious if that's also your experience, that folks tend to use melatonin as a sleeping pill. And then sometimes, well, number one, it doesn't work that way. But you know, number two, then there's increased frustration because then it doesn't work. They're not falling asleep. So certainly we do use melatonin with some of our young people. We can see that it's very effective. And our goal is also to use that in combination with behavioral strategies.
Thanks. And I know there's a couple hands raised, so we will definitely get to those folks too. Quick question on, is there any data that shows later start times in high school causing later bedtimes? If school starts later, are parents seeing that their teens are staying up later as a result? So we were just wondering if there's anything, are there any trends from schools that are seeing that they've made the later start time?
It's a great question. And that is like one of the top questions I get about that. There was no change in bedtimes when school was delayed, because that was actually some of the pushback from some of the school districts that, well, kids are just going to stay up later then, and they're not really going to get any more sleep. That was actually not the case. Much of these data are out of Colorado and Wyoming, where in several districts, they adopted later school start times and carefully studied outcomes. So when given the opportunity to sleep later in the morning, the kids went to bed on average at the same time. They slept more by sleeping later in the morning.
Another question too is about parental involvement. How can we get more parents involved, because they will be implementing many of the strategies at home? And are there any resources that you would suggest that we share with families? And I know Dr. Goldstein and you and I spoke too about one of the things that we love about sleep is when you're talking about suicide prevention, it's like everybody sleeps. It's a conversation that we can engage parents in about sleep hygiene and how this is going to help your child overall. So I don't know if there's any resources, or if you can share additional resources that I can share out with the group through email.
Absolutely. I'm happy when I send my slides along to you, I can also send along some resources for, for families, for young people, for clinicians. There are hosts of resources out there. In terms of involving parents, I think we just want to be mindful about respecting adolescents' autonomy, which is part of that normative developmental period. And also figuring out ways, and usually I do this with the adolescent. So we're making goals in our treatment together and talking about, what ideas do you have for ways that your parent can support you in achieving these goals? Maybe in getting to bed earlier at night, or, remembering to wear your blue blocking glasses at night, or whatever it might be. Because oftentimes by the time folks get to us, I work in a suicide prevention clinic, that they, sleep has actually become kind of a battleground between the parents and the kids, primarily because the kids can't get up in the morning to go to school. The parents are angry. They're all kinds of things, screaming, yelling, trying to pull people out of bed, pulling covers off, right? And understandably, I'm a parent too. I get it. Like, you got to get up and get moving. It's really hard. And so, we also want to be mindful not to increase conflict around sleep during this period. And oftentimes, parental involvement that the adolescent is inviting can be incredibly helpful in changing some of these sleep behaviors.
A question about any benefit to having a blue light blocker screen protector on the phones. Are they effective?
Yes. And I should also say, particularly during those like 2 hours before bedtime. And so that's really where most of the literature has been in the sleep health field, has been looking at their impact during those 2 hours prior to bed.
We do have a couple hands raised too. So Kelly, if you want to unmute Kelly Baker, and unless I hit your
Hi.
Hi, Kelly.
Hi, thank you. It's more of a comment really, but I wanted to thank you because this is such an important topic. I'm a screener, I'm an adjunct psychology professor. I've had 3 teenagers, I'm a mother, and I have a sleep disorder. And I just wanted to, it's really, as no matter how many times I've seen it clinically, no matter how many times I've taught it to my student, until I experienced it myself, I can't tell you how important it is. And all of us take it for granted, I think. I had surgery a few months ago to get a sleep apnea implant, and I've noticed the difference is night and day. It totally changes so much, and I just wanted to just put that out there and remind ourselves to practice what we preach, because I think we all want to work. Oh yeah, I'll pick up extra shifts, sure, whatever, I can sleep in, and it does affect people more than they realize. So thank you.
No, thank you, Kelly. Latanya also has your hand raised. Perfect.
Yes, hi. I wanted to make a comment as well. I was glad to hear that someone asked about whether there was a study for adults, because I find that when I hit the snooze, and fall back to sleep, I will have the craziest dreams, like just stuff that absolutely makes no kind of sense. And then, but I was happy to hear you say about the brisk wake up. And the first thing I do is plant my feet on the floor and open my blinds. Like that's if I don't do that, I even had to take off the what are those panels, curtains, room darkener curtains. I had to take them off because it made me never want to get up ever.
Oh, yeah.
And so, I'm really am curious of how the studies would be for adults as well. So I'll be looking out for that. Thank you.
Absolutely. And
Awesome.
Latanya, I love what you said. It reminds me how much to mention increasingly we're studying the sleep environment, how much the sleep environment matters, particularly among young people. I was actually just looking at some recent data from a pilot trial of that transdiagnostic sleep and circadian intervention among young people identified in primary care. And 80% of them said that their room was either too hot or too cold, their bed was uncomfortable, there was light coming in or no light coming in, right? All of these things really matter for the quality of our sleep.
Yeah.
And by and large, those are things that sometimes with some creativity, we can actually help improve.
Yeah, yeah. So this is very interesting, and I'm glad to just hear more, about this.
Thank you.
So, and again, Dr. Goldstein, a lot of like thank yous and enlightening and
Thank
really
you.
helpful and grateful. Looking to see if anyone else wants to unmute, or I don't know if Laura or Brett happen to get direct questions either. Like we'll check up anyone
Maureen,
last
another
call
one
for
just
hand
came
raising
in.
or
One just came in the chat that says, any thoughts on using a wake up lamp? It could be difficult for students to have to wake up before the sunrise.
Oh, yeah. So, I mean, what we know is that light helps to anchor our circadian rhythms, and particularly like in the dead of winter in New Jersey and in Pittsburgh, and like these kids are getting up at 5, 6 a.m. There is no light to be had. And so absolutely, if that's something that the young person finds is helpful and that's part of their morning wake up routine, that can certainly be beneficial. And particularly for those young people who have a tendency to snooze, pull the blankets over their head, who need, despite our best attempts to get them this brisk wake up, need something a little more gradual. It's certainly worth a try. I am all for whatever works with young people and whatever they're willing to try. And I think some of the newer technology has been really appealing to some of the kids we work with, which I'll take it if it means it's going to help them get out of bed.
Cheryl has her hand raised. So if Cheryl, you want to unmute?
Yes.
Thanks.
First and foremost, Tina, I just want to say thank you for this presentation because it was really enlightening for me. And the other thing is, I wanted to say, like, I used to years ago have issues with sleep. Because, like one of the other ladies mentioned, as a crisis screener, you're picking up all these different shifts and everything just so you can get extra money, meet goals, but you don't know how it affects your internal clock. One thing that had changed in 2014 was I changed my diet, and now I cannot snooze ever. Like as soon as my eyes pop open, it's like my body is ready to go, jump out the bed. And the other thing is I never sleep with an alarm clock anymore after I change my diet. So it's like my body is automatically set. And then yeah, and then the last thing is I heard about the thing about changing the time with the schools, right? And I know we're not saying all schools across America start late for kids, because you do have some children are early risers, like my granddaughter. She's an early riser, and that's something that we got to take in consideration, that we don't want to affect the early risers. And then my other thing is, and this is a question, how do you think that it would affect the workforce? If you got children going to school later and you have to be to work earlier, like how would that come into play?
Yeah, Cheryl, you put your finger on so many important points. So we'll start with the later school start times. So like so many things, these are complicated issues. You're absolutely right. I wish that we could just prioritize young people's mental health, but there are good reasons that schools start so early. We all have to get to work, right? If my kids didn't need to go to school until 9 o'clock, how am I going to be at work at 8, right? And so that has absolutely been one of the concerns among constituents, among, educational systems. Others have to do with, busing schedules. And I mean, there are many, many considerations and reasons why it's not nearly as simple as I wish it were to let's just start school later. And so those are really good questions and considerations, and part of what I think has made, even though the science tells us that this would be great for our children, you know, there are very valid reasons that it's not so easy to implement. So that's the first point, and I really appreciate you raising that. You had also mentioned about the shift work, and I'm so glad you mentioned that, because that is there is a literature around that in adults. And so finding much higher rates of depression, anxiety, suicidality among people who do shift work, and particularly night shift. They're not exposed to daylight during the day. They're sleeping during the day. Maybe their shifts are, moving around. And so their sleep is not regular, has been shown actually to be associated with a lot of health problems, not just psychiatric symptoms and suicide risk. And so recognizing that, our bodies have this clock. And what you pointed out is that when you got on this really kind of regular schedule of eating and sleeping, you felt better, right? And your body was really more able to just get itself into this rhythm. So I really appreciate you bringing that up. I think
Dr.
there was
Goldstein,
one more point.
to be cognizant of your time too, and if there was another question about and if you want to send it to me, you can also send it to me. Has there been research done on females, and is there any association with hormones and periods and their sleep and risk of suicide?
That's a really good question. I know there's been a lot among perimenopausal and menopausal women, because we know that that's a period of life, particularly for individuals who are female sex at birth, who that those hormonal changes have really significant impact on our sleep. I'll be honest, I don't know as much about that literature, but I'm happy to put folks in touch with. I have a wonderful colleague here who studies that life period, and I'd be happy to make some connections there. And in terms of, younger people, I think we don't really know yet so much about sex differences in terms of sleep difficulties and their association with psychiatric disturbance. We do know that there are some changes during, right before a young woman's period and then during, that can also contribute to more difficulties with sleep. We don't yet know if those are also associated with increased risk for suicidal behavior over and above just having sleep difficulties. So I think those are great questions for the field moving forward.